operating companies serve more than 1 million dentists in over 150 countries.
And while that makes us proud, we're just getting started. Driven by a culture of innovation, we're committed to continuous improvement. And that's no buzzword, it's who we are.
Envista operating companies have one of the largest research and development teams in the industry
and offer over 20,000 global and online trainings each year, which has resulted in more than 1 million professional customer partners who rely on our technology every day. We partner with professionals to improve lives by equipping professionals for success and providing side-by-side, end-to-end support to every single one of our customers. What does it all add up to? 125 years of industry innovation. We're not the new kids on the block. We're experienced, smart, and agile, able to invest in new potential. We are Envista, and we champion creators of confidence. Creating confidence is no small business. With decades of world-class experience, the people behind Envista know this well. That's why our deep industry roots and Danaher heritage lead the way as we champion creators of confidence around the globe.
Envista operating companies serve more than 1 million dentists in over 150 countries.
And while that makes us proud, we're just getting started. Driven by a culture of innovation, we're committed to continuous improvement. And that's no buzzword, it's who we are.
Envista operating companies have one of the largest research and development teams in the industry
and offer over 20,000 global and online trainings each year, which has resulted in more than 1 million professional customer partners who rely on our technology every day. We partner with professionals to improve lives by equipping professionals for success and providing side-by-side, end-to-end support to every single one of our customers. What does it all add up to? 125 years of industry innovation. We're not the new kids on the block. We're experienced, smart, and agile, able to invest in new potential. We are Envista, and we champion creators of confidence. Creating confidence is no small business. With decades of world-class experience, the people behind Envista know this well. That's why our deep industry roots and Danaher heritage lead the way as we champion creators of confidence around the globe.
Envista operating companies serve more than 1 million dentists in over 150 countries.
And while that makes us proud, we're just getting started. Driven by a culture of innovation, we're committed to continuous improvement. And that's no buzzword, it's who we are.
Envista operating companies have one of the largest research and development teams in the industry
and offer over 20,000 global and online trainings each year, which has resulted in more than 1 million professional customer partners who rely on our technology every day. We partner with professionals to improve lives by equipping professionals for success and providing side-by-side, end-to-end support to every single one of our customers. What does it all add up to? 125 years of industry innovation. We're not the new kids on the block. We're experienced, smart, and agile, able to invest in new potential. We are Envista, and we champion creators of confidence. Creating confidence is no small business. With decades of world-class experience, the people behind Envista know this well. That's why our deep industry roots and Danaher heritage lead the way as we champion creators of confidence around the globe.
Envista operating companies serve more than 1 million dentists in over 150 countries.
And while that makes us proud, we're just getting started. Driven by a culture of innovation, we're committed to continuous improvement. And that's no buzzword, it's who we are.
Envista operating companies have one of the largest research and development teams in the industry
and offer over 20,000 global and online trainings each year, which has resulted in more than 1 million professional customer partners who rely on our technology every day. We partner with professionals to improve lives by equipping professionals for success and providing side-by-side, end-to-end support to every single one of our customers. What does it all add up to? 125 years of industry innovation. We're not the new kids on the block. We're experienced, smart, and agile, able to invest in new potential. We are Envista, and we champion creators of confidence. Creating confidence is no small business. With decades of world-class experience, the people behind Envista know this well. That's why our deep industry roots and Danaher heritage lead the way as we champion creators of confidence around the globe.
Envista operating companies serve more than 1 million dentists in over 150 countries.
And while that makes us proud, we're just getting started. Driven by a culture of innovation, we're committed to continuous improvement. And that's no buzzword, it's who we are.
Envista operating companies have one of the largest research and development teams in the industry
and offer over 20,000 global and online trainings each year, which has resulted in more than 1 million professional customer partners who rely on our technology every day. We partner with professionals to improve lives by equipping professionals for success and providing side-by-side, end-to-end support to every single one of our customers. What does it all add up to? 125 years of industry innovation. We're not the new kids on the block. We're experienced, smart, and agile, able to invest in new potential. We are Envista, and we champion creators of confidence. Creating confidence is no small business. With decades of world-class experience, the people behind Envista know this well. That's why our deep industry roots and Danaher heritage lead the way as we champion creators of confidence around the globe.
Envista operating companies serve more than 1 million dentists in over 150 countries.
And while that makes us proud, we're just getting started. Driven by a culture of innovation, we're committed to continuous improvement. And that's no buzzword, it's who we are.
Envista operating companies have one of the largest research and development teams in the industry
and offer over 20,000 global and online trainings each year, which has resulted in more than 1 million professional customer partners who rely on our technology every day. We partner with professionals to improve lives by equipping professionals for success and providing side-by-side, end-to-end support to every single one of our customers. What does it all add up to? 125 years of industry innovation. We're not the new kids on the block. We're experienced, smart, and agile, able to invest in new potential. We are Envista, and we champion creators of confidence. Creating confidence is no small business. With decades of world-class experience, the people behind Envista know this well. That's why our deep industry roots and Danaher heritage lead the way as we champion creators of confidence around the globe.
Envista operating companies serve more than 1 million dentists in over 150 countries.
And while that makes us proud, we're just getting started. Driven by a culture of innovation, we're committed to continuous improvement. And that's no buzzword, it's who we are.
Envista operating companies have one of the largest research and development teams in the industry
and offer over 20,000 global and online trainings each year, which has resulted in more than 1 million professional customer partners who rely on our technology every day. We partner with professionals to improve lives by equipping professionals for success and providing side-by-side, end-to-end support to every single one of our customers. What does it all add up to? 125 years of industry innovation. We're not the new kids on the block. We're experienced, smart, and agile, able to invest in new potential. We are Invista, and we champion creators of confidence.
Life keeps us busy. Let's make it simpler. Much better, don't you think? Let's try that again. So clean and simple. Can't find what you're looking for? You know what to do. Here's Simplicity by Kerr. 3 trusted brands designed to help you streamline your inventory and workflow, so you can spend more time with your patients. See, isn't that better? To learn more, go to go.kerrdental.com/simplicity. Life keeps us busy. Let's make it simpler. Much better, don't you think? Let's try that again. So clean and simple. Can't find what you're looking for? You know what to do. Here's Simplicity by Kerr. 3 trusted brands designed to help you streamline your inventory and workflow, so you can spend more time with your patients. See, isn't that better? To learn more, go to go.kerrdental.com/simplicity.
Good morning, everyone. Thank you for giving up your Sunday morning to join us online. Selecting the right treatment options in daily practice has become a real challenge. The Simplicity webinar series aims to provide an interactive platform to champion dental practitioners, enhance patient care by optimizing materials, equipment, and clinical techniques for direct and indirect restorative procedures. My name is Assis. I am the commercial manager for Kerr in APAC, and I will be the moderator for today's session. We will have a live Q&A session at the end of the lecture, so please do type in your questions in the Q&A box, and these will be taken up at the end of the session. Today's topic is Simplified Direct Resin Artistry, Materials and Techniques for Success with Dr. Aodhan Docherty. Dr. Aodhan is a graduate of the University of Sydney, Bachelor of Medical Science and Bachelor of Dentistry, completing his studies with honors and a university medal. He has engrossed himself in postgraduate education, becoming alumni of the Fall Cosmetic Academy, the Caius Academy, completing a 2-year orthodontic mini residency through EODO and the City of London Dental School, and has completed a graduate diploma in clinical dentistry in oral implants at the University of Sydney. Dr. Aodhan is passionate about mentoring and teaching and is an examiner of postgraduate oral implant diploma at the University of Sydney. He believes in literature-based approach to dentistry and is an author of the Wiley-Blackwell textbook, Practical Procedures in Implant Dentistry. Currently in private practice in Sydney, he enjoys a mix of general, implant, and aesthetic work. We are very excited to have you with us today, Dr. Aodhan. And without any further ado, I hand it over to you to begin the session.
Thanks for that lovely introduction. I appreciate everyone spending their Sunday with me. And I'm really excited to discuss with you guys today lots of different aspects of composite and how we can simplify our work so that it benefits both the patient and ourselves in the long run. I'm just going to get up my presentation here. Just let me know if you can't see it or anything like that. Perfect. Is that maximized now? Awesome, awesome. So we're talking about direct resin dentistry. as a clinician myself, this is my bread and butter. This is something I'm very passionate about. It's something I do every single day in clinical practice for my patients. This is where I'm from. I'm from a little beach in Sydney, Australia, and it's cold today. I'm inside and I've got a jacket on as well. It's a winter's day. It's blue sky. It's freezing though. Okay, so for me personally, this is where I practice. I have a few private practices in Sydney. I've been very lucky to have been mentored by some amazing clinicians, prosthodontists, periodontists, and laboratory technicians. Through the past roughly 10 years, I've opened these practices here, and these are the practices. We have a general dentistry, but also a cosmetic focus as well. So we offer kind of all aspects of dentistry. And this is a practice that I'm building at the moment. It's down at in the city of Sydney, and anyone who visits is always welcome to reach out to me and come and have a chat, come and visit the practices. We're building this one. It's nearly complete. It's going to be boutique dental practice, essentially just for composite resin dentistry, just for porcelain veneer dentistry, and just for Invisalign, being the three big things that I'll be doing there. And in terms of my background, I've got a very mixed background. I've done lots of postgraduate studies over this past decade. So you'll see the cases that I show you today, and I'm going to show you lots and lots and lots of cases. I'm going to show you lots of clinical tips, techniques. I hope I don't speak for too long. You'll have to interrupt me if I do. But where I'm getting all of these aspects from is different segments. So over in Brazil, learning composite with Newton Fowle, who is basically the gold standard for composite resin dentistry. Over in Sydney here, and in Australia, learning orthodontics. You'll see I do a lot of Invisalign. So for a lot of my cases, I might do some pre-pros ortho so that my composite resins or my porcelain are in the best position that they can be. They're not too thick, they're not too thin. I can make sure that the color, the shade, the value is correct, and it's the best it can be as well. So you'll see that I do a lot of Invisalign and a lot of orthodontics. I work with orthodontists and periodontists as well. In terms of what I love doing, and as a passion besides dentistry, is teaching. And you can find some of the stuff that I've done in some of these, which I'll talk about a bit later. But the main question of today is, why should we simplify direct resins? Why are we trying to simplify it? What's the point of simplifying it? And there's a few reasons why, and we're going to go through each reason. I would say that one of the main reasons I would raise first is that it's technically difficult. It is not an easy thing to do, layered direct composite resins. And you'll see some cases here. I want to preface this with showing you guys some issues that I've had, to show you some areas where I've felt like I needed to improve with dentistry. And technically, it is very difficult to do complex layering. So I was always looking for something to simplify my approach. And in terms of the first thing we have to talk about is shade selection. So shade selection, this is kind of what I always used to have. I used to have a big tackle box of composite, and I would have a few of these. These are like fishing boxes that fishermen would put their lures in, and their hooks and things like that. And I'd go to a fishing shop and I'd regularly buy these. And the guy at the fishing shop would be wondering why I'm buying so many tackle boxes. Wasn't that I was into fishing, it was actually that I needed to put my composites in them. I needed to put my enamel shades, my body shades. I needed to put my dentine shades. I needed to put my effect enamels, my translucent shades, my clear, my blues, my ambers. And so I was holding so much composite resin that it was making my shade selection quite difficult. And we all know that we can make a tiny error in terms of shade, and it can come back to bite us later. The patient comes back for review, and what do we see? Immediately we see the wrong color, the wrong value. So shade choice is very important. And we're often like this person here sitting in this picture, unsure which avenue to go down. And by simplifying our shade choices to a smaller number, I found that makes that shade selection, the correct shade selection, I should say, much more highly likely to occur. So here's a case, for example. This case was done some 8 years ago now. I did some orthodontics before. So this is how the patient presented: an injury to her 2-1. She had an old composite resin placed there for about 15 years herself. And I wanted to do some orthodontics to straighten everything out. And she wanted that as well, so we could provide her the best possible result. And you'll see here, she's straightened everything. She's whitened everything. The teeth look like they're in a beautiful position. The shape of that 2-1 looks beautiful. The outline form, you can see I've put beautiful secondary anatomy, which we're going to talk about a bit later as well. The line angles are very nice on the surface of the tooth, but the shade is not right. I've used a shade that is completely wrong actually for this patient. And that's because I remember I jumped into this case. I didn't choose the shade at the start of the appointment, which I always do now. And I left it to the very end of the appointment to choose the shade. So a tip is always to choose your shade as the first thing you do. So what do I do with a patient? I let them know when I sit down face to face with them that during the appointment, their teeth are going to dry out quite a lot. Their teeth are going to dehydrate as they've got their mouth open, as they've got a rubber dam on, as we're drying the teeth, as we're etching the teeth are going to get dehydrated. So the shade of the adjacent teeth here is going to change. Okay, and as the shade changes, that means that our chance of picking the right shade or selecting the right shade is going to get worse and worse and worse. So what we need to do as the first thing, even before I give local to a patient, I choose the shade. I put 2 cotton rolls under their lip. I have the composites ready and they're basically expressed. I roll them up in a ball and I place them on the tooth. And I do custom shade tabs. So for these patients, I do custom little shade buttons, which I'll show you in a moment, so that I can choose the shade, so that when everything else dehydrates and change color, I know I've picked the right shade. And I always warn the patient at the very start of the appointment that we are choosing the shade at the start because their teeth are going to change in color. Now, when I sit them up and they look in the mirror later, it's going to look good, but it's going to get better and better and better over the next 12 hours as their teeth rehydrate. As they've got their lips closed, as the saliva goes into the enamel, it's going to rehydrate and get better and better. So always say that at the start of the appointment, because if you say it at the end of the appointment, it sounds like an excuse. So it's always better to say at the start than the end. And they're going to be much more critical if they think that it's an excuse at the end as well. So you'll see in this patient, the best way to determine what's wrong with this shade is by turning it to black and white. Now, why do we turn photos to black and white when we're looking at shade? Well, by turning it black and white, we eliminate the need for our eyes to use the cones, and we're actually going to be using the rods, which are at the back of the eyeball. Now, the rods allow us to see bright and dark, basically black and white, and we've actually got a lot more rods than cones. Even though we use cones every day for all of the different colors, we actually have a lot more rods. So it's a lot more accurate to determine shade selection with looking at a black and white photo. And so for me, I always take a photo with my camera and I turn it to black and white to select the correct shade. And we know that shade selection was traditionally done with the Vita Shade Guide. Now, why was it originally done with the Vita Shade Guide? It was done because we had our shades all in that guide. We would hold the shade guide up and we would go along until we stop and we'd say A3, we'll pick A3 out. We'd look at A3, we'd say, yep, nurse, can you please get me an A3 composite resin? But we know that that's not accurate at all. This Vita Shade Guide is not going to be corresponding to any of the composites that we have, because the Vita Shade Guide is made of acrylic, a plastic material, is different from composite resin. So we shouldn't be using this shade guide for our shade selection for our patients. What do? I sit down and I draw a color map. Okay, so I take some photographs of the patient before their teeth are rehydrated during the initial consultation. And before the patient comes in for their composite resin, I actually draw on the piece of paper. You could do this digitally as well. And I basically jot down a color map. I jot down what colors I'm seeing. I'm jotting down on the incisal edges here. You can see if there's any translucency, or if there's blues, or if there's orangey amber colors. And so I get that map ready. And so then when I sit down with the patient, I actually have composite where I can put it on the tooth and I can cure it. And I can then determine with a black and white photo which composite is going to be most predictable, most accurate. Okay, so in this photo here, you can see there's 2 composites on the middle third of the tooth. and there's one composite on the incisal edge of the tooth. Now, what composites go where? Well, you'll see in the following diagram, basically, that the composite that needs to go in the middle is the enamel. The composite which goes at the gingival is the dentine, and the composite which goes on the edge is your effect enamels. So if you're doing complex layering, you have to be very, very, very careful in terms of shade selection, because you've got so many shades to select. Whereas if we have a single composite that we use, a simplified technique, we only need to have one. Now, with this system here, what I'm doing is I'm putting composite buttons, as we call them, in the middle of the tooth, because those are some enamel shades. Or I would get my Simply shade, a simplified composite, and I would put it in the middle and I would cure it. And then I would turn it to black and white, and I would have a look to see which composite is closer in terms of the value, the black and white, to the tooth below. So we can see here that the one right in the middle is going to be closer than the one on the outside, which is going to be a bit brighter. So when you're doing your composite shade selection, do it at the start of the appointment, explain it to the patient, and use shade buttons like this with a few different composites. Okay, make sure you cure it, because the color of the composite will change after you cure it. So you don't look at it uncured, and then that will give you an accurate representation of what the shade is. And we're looking at value. Okay, because the rods in your eyes are more numerous, and that will be more predictable than looking at it with looking at it with a color photograph, or looking at it just with your eyes. Okay. So shade selection is one thing which is difficult with composite resins in anterior zones. Another thing which is difficult is the layering techniques. So I want to show you guys what my mainstay of treatment used to be for every single patient coming in for an anterior composite. And I want you to bear with me, because it's quite a lot of steps to build up an anterior tooth with a multiple shade technique. So this is as I said, the approach I used to use for every single case. Now, this is a patient, and she fractured her 1-1 and her 2-1. And she fractured those teeth while she was over in Italy about 5 years ago. And she was over there, she was on a moped one night, she had a few drinks and she fell off the moped, and she fractured her 2 front teeth, which was devastating to her. And when she fractured them, she went to an emergency dentist and they patched up those incisal edges. But you can see that the color isn't quite right. Okay, the color that is on there is very deep, it's very chromatic, it's very rich, and also the shade isn't quite right, and also the shape isn't quite right either. You can see that the shapes are different, so they're not symmetrical, and you can see some on the 2-1 it goes up, and on the 1-1 it goes down like this. So she came to me after she came to me from another state. She'd seen many other dentists, about 4 or 5 actually, who had all recommended indirect restorations for her. And she said to me, listen, I wanted an alternative that was not indirect. Her words were, that weren't veneers. I don't want my teeth prepped. Can you give me an alternative that is composite? Because I'd done some composites for some of her friends or colleagues. So I looked at the case in detail, and I needed to do a bit of a smile design first, because she's a very picky patient. So we looked at different shapes, and you can do this with PowerPoint, Photoshop, or you can just do this with a pen and paper, which is what I nearly always do. Print it, sit down with the patient and draw some different shapes. And I established the shape that she liked to start with, and I established it that it was closed up. I would have opened those incisal embrasures between the front 2 teeth, but she actually wanted them more closed. That was the look she liked. Okay, so number 1, I get the shape right. Number 2, I then need to plan for what shades I'm going to use. And as said, this is how I used to approach all of my anterior layered cases. And you can see I'm using at least 4, but sometimes 5 shades. So what does that mean? That means I need to be very, very picky with which shades I'm using. And you can see here, I used an A1 enamel harmonized, I used an A2 dentine harmonized, and I used a translucent and a blue. So it gets pretty complicated when you're doing technical layering like this. Okay, so I'm using 4 different shades here. I started off by mocking up in the patient's mouth the shape that she liked. And this is an alternative if you don't want to pay for a wax up. And this is what I do mostly for my composites, if I need to do a wax up, it's going to cost money and time, and I can reduce the cost that I pass on to the patient by actually doing a direct mock-up in the patient's mouth. I get some old composite and I apply it to the teeth and I shape it without etch, without bond, without any surface preparation. And I actually can get the shape that the patient likes, and I can adjust that shape with a red disc or with like an opti disc or with a burr. And I stand the patient at the mirror and I get them to look at the shape, and they consent to the shape that we're going to make. The patient here wanted to maintain a small diastema, for example. So this allows me to communicate very effectively with her what the shape will look like in the end. Okay, I tell them, don't worry about the shade and the color, etc. We're going to get the shape right first. And I can take a putty key, which is basically a PVS. I roll it up and I put it on the back of the teeth in a putty key material. And I have then got the shape before I do any of the dentistry. Okay, this is my go-to isolation for any of my anterior composites, and it's called a split dam isolation. And with a split dam isolation, we use 2 rubber dam clamps. So here you'll see I'm using the Kerr soft clamps. The Kerr soft clamps you don't need to give local anesthetic for, which is something that patients really like. Okay, they always prefer not to be numb. A lot of mine do anyway. So using a Kerr soft clamp is nice. It doesn't give too much gingival irritation. I tell the patients that it's going to be tight, but it's not going to be uncomfortable. I put the 2 clamps on and then I stretch a rubber dam across. And I think I've got a little video here in a moment showing you how I set this up. But the benefit of this is that you are not then having the patient close. They're not contaminating the area with saliva. The humidity of their breath is not contaminating the tooth surface. And we're able to apply our composite resin to areas like this and maximize the adhesion to the enamel. Okay, so a split dam type technique, how do we do it? We get the rubber dam sheet and we punch 3 holes in it with our hole punch. We then get a pair of scissors and snip between. So essentially you've got a triangle and a little flap. I put the 2 clamps on the 6s, which you'll see in a moment here, and I stretch the rubber dam across and fold it underneath the lip here. I then get a dry guard or a dry tip, something to put in the palate, and I fill the palate with PVS material. That allows me now to work on the patient without them closing, and they're pretty comfortable under there as well because they don't have any water building at the back of their throat or anything like that. So these are the existing restorations. I then have the task of removing them. So I've removed the restorations here, and you can see here from the next shot, there's lots of enamel. Lots and lots of enamel. So there's no need to go to an indirect restoration for a case like this. I've got follow-ups of 10 years or 8 to 10 years now where I've done cases like this. The cases look beautiful even at that amount of time, and they're not fracturing. And if you've checked your occlusion and you've made sure the bite is correct, you've accounted for parafunction and other things like that because there's so much enamel to adhere to. So this is a perfect case for composite resin. I etch the surface. I'm only etching the enamel after I've cleaned the surface either with pumice or with an air abrasion material, which are 27 micron particles that clean the surface. And then in this case, I used OptiBond XTR because for me, I've used this 5th generation system now for the best part of a decade or so. Okay, so OptiBond XTR has always been my go-to. I'm starting to branch into OptiBond Universal, but OptiBond XTR has always been my go-to. You'll see on the right-hand side here, in this layering technique, which is quite complex, I'm building up a palatal shell. And how do I build the palatal shell up? I use the putty key, which I took from the mock-up before. I then actually start to build the walls and the edges up as well. So I use a translucent shade for the palatal area. Then I use an A1 enamel to build up the shell and the incisal edge. I then get my dentine shade and I layer it into the middle part of the tooth. So you can see I've created these beautiful mamelons. And then I've layered enamel on top, and I go through the polishing and contouring stages to correct the surface anatomy and to correct the surface polish and texture. What do I often use? I use an OptiDisc and I use a red flame on a red band handpiece, an electric handpiece. I rarely ever use a high-speed handpiece for any of my dentistry at all. The reason why is that a red band handpiece, which is electric, has torque control. So you're not going from 0 to 100 and then back down and up again. You put your pedal down and it's a very consistent rotation of the burr. So we're not going to create divots and little, we're not going to create little undulations on the surface. Now, why am I drawing with pencil on the surface here? And I do this for multiple layers, and I do this for a single layer technique as well, where I'm drawing the surface anatomy and I'm creating where I want my line angles to go. And I'm drawing the secondary anatomy, what we call the lobes and we call the depressions. And I'm also marking the thirds of the tooth as well, the facial thirds. And this is where I use my burr here. And you can see this is immediately post-op. So you can see here that we're getting some beautiful translucency coming through. We can see the mamelons. We've hid the transition line. You can't see where those fractures are. And this is after a couple of weeks of rehydration of the teeth. So we've been able to take our case from something like this to our plan and to something like this. How long does this take though? And how much does this cost the patient is the key here. How long does it take? This sort of case for 2 teeth will take me at least 3 hours. And you'll probably all be laughing at that right now because you'll think, my God, 3 hours. How is he spending 3 hours on a patient doing 2 composite resins? Surely you're not going to be able to, with a 3-hour time, surely you're not going to be able to maintain your hourly rates, your billing, the time frame that it takes. And this is what I also came to think of with time as well. And the reason why is because 3 hours, I need to account for my nurses' wages, my staff wages, paying myself, paying the overheads. So how can I have a simpler technique than taking 3 hours for these 2 composites? And is there anything else available these days? Maybe a single shade or 2 shade technique. Okay, so that's what I came to conclude. And you'll see that is money and time is the big things that, kind of, it's not just for us as dentists. I am more than happy to sit down there for several hours doing this work, but for the patient, it's uncomfortable for the patient to sit for 3 hours with their mouth open. And the cost I need to pass on to them is a lot more, maybe 3 or 4 times more than a normal composite. So this left me thinking, should this be my only technique that I offer for every single anterior case? And the answer is no. The other thing I would say about holding that much stock of composite is that it's not effective as a business owner, any business, to hold that much stock. You can't run a successful business with having boxes and boxes of composite. And you guys will know that you'll look through your composites every so often and you'll have dozens of expired composite tubes or capsules, which is just such a waste. It's such a waste of the practice's money, and it's a waste of plastic, and it's a waste for the environment to have that much wastage that's just getting thrown in the bin. So holding too much stock. So I'm thinking to myself, it's complex in terms of shade selection. It's complex in terms of technique. I'm holding way too much stock, which is costing the practice money as well. What can we do to overcome these challenges? So can we reduce inventory somehow? Can we simplify the shade choice? Can we have trust in that R&D that we're using? Can we have, it's all too common that you'll get reps that come along and they'll say, listen, I've got this amazing product. I want you to try it out. And you say, okay, how long has the product been out for? And they'll tell you, oh, the product's been out for about 2 weeks. And automatically for me, when I'm hearing that, I'm thinking, well, I don't really trust that if it's only been out for 2 weeks. Who else has been using it? Have I got long-term studies? Have I got evidence to support what I'm doing? As Sis introduced, I based a lot of my dentistry on literature-based approaches. And so I need to have some sort of background and some literature to support what I'm doing. So having trust in the R&D is very important. Otherwise, I say to them, come back to me in 5 years, show me some studies at 5 years, and then I might start using your product. And avoiding complex layering procedures as well. And this is where Simply Shade or Simplify comes in. And just excuse me for one moment. Just got a little bit of a cold here. It's just so it's very cold weather over here at the moment. So Simply Shade or Simplify is a new generation, basically a new way, I should say, of looking at composite resin dentistry for your anteriors. And why is it new? Well, it's new in that we're using a smaller range of composites. So we're using a light, a medium, and a dark. We're using a bleach and an opaque. So you've only got 5 shade choices. And in my practice, I rarely use medium, I rarely use dark. So I'm only really going to be using light or bleached. So for me to have 2 shade choices instead of 50 shade choices is a huge advantage. It saves me time. It saves me time that I need to pass on cost to the patient. And it also saves me the difficulty of selecting that shade if I've only got 2 choices. Now you have got, for example, older patients though, access to using dark or medium. Okay. And if you have something where you need to opaque out the tooth below, or you've got a patient who wants a really opaque restoration, then you've got an opaque. So you've got 5 choices in total. And you can see here the light, medium, and the dark. And how this works is that the light shade of composite is actually able to blend in a chameleon effect with A1, B1, B2, C1, and D2. It's fairly amazing. And you look at the medium and the dark, and it's very similar. These shades are actually able to allow light to pass through to pick up the tooth structure color below, and for that to be picked up by the eye. So you can see the Vita shade equivalent. So basically what this shows you is that Simply Shade is able to capture with just these 3, for example, the whole entire Vita shade system. Okay, so you don't need to be stocking A1, B1, B2, C2, all that. You don't need to be stocking 50 different composites. You can stock a very small number and cover the range. Now, as I said, I don't trust people all the time when they come in and say to me, Aodhan, listen, I've got this brand new product, go for it. Can you be our test subject here and start using it? I want to see evidence and I want to see literature. And why I've started using Simplify or Simply Shade, as we call it here, is because this technology has been around for quite a long time. So I've been using Kerr's composite now for well over a decade. I've used it in Herculite. And Herculite was then turned into Harmonize. And Harmonize around 2015, when I started using it about 7 years ago, was a big change for me, because in terms of moving from Herculite to Harmonize, we started to have this amazing, beautiful handling of composite. And we went from a micro to a nano technology as well. So for me, this adaptive response technology, as it's been coined, basically means that it's a nanoparticle composite. Okay, so it's a nano composite, which has the superior physical properties. So in terms of all your physical properties, it ticks the boxes, and it's superior to any other types of previous generations of composite, and it maintains its luster. Okay, so you might have known your micro composites to having beautiful surface finish, but they quickly lose that surface finish as the particles break off. With a nano, you've got different technology here where you've got nano hybrid technology. You've got this beautiful surface finish, which is maintained as well. And it actually has technology where as the surface wears, it actually self-polishes. So it's quite amazing technology. I'm not a tech head. I'm not a material scientist or anything like that. But this is some of your material science here. Its physical properties come because it's got zircon particles and silica filler. Okay, and it's very highly filled. So for a composite that looks this beautiful, it's actually very highly filled. And usually that can't be the case. It's usually either highly filled and it doesn't look nice, or it's low filler and it looks nice. But they've actually got a balance with the exact type of hybrid that they've got and the types of filler particles and zircon particles. Okay, so this is able to compensate for aesthetics. And something I really like about it is that it's thixotropic. So what does that mean? It means that when you have a composite, you'll probably know some of the other composites, you apply to the tooth or you apply to a mixing pad, and it basically goes everywhere. It slumps and it almost looks like it melts. Well, this composite doesn't do that. It maintains its form and it maintains its 3D, basically its 3D form. But when you push it, it actually is thixotropic, which means that it's nice and easy to push. So it's able to hold its form when it's not being manipulated, but when it's manipulated, you can easily manipulate it. So it's got this beautiful, it's almost, you think, is that even possible? But it's the way that there's a modifier in there, and it's the way that the particles are designed in the nano hybrid technology that's used in it. So it makes handling very nice. And the other thing I love is that it's not sticky, because sticky composite absolutely does my head in. I can't handle sticky composite. I don't want my nurse to be wiping my instruments every single time I touch the composite, because that, again, that's time, and that's also the risk of putting the little particles of the gauze, the little lint particles that you never see them, and then for some reason when you're doing a composite, they're everywhere. Those are the things that I don't want on my composite. And if the nurse is wiping your instruments as they usually would with a gauze, you've got more risk of those little particles getting put into your composite. Okay, so that's why I really like it, because it's not leaving resin residue on the surface as well. And we can avoid complex layering. So here's a case. This was a case that came into me, was it last week before? It's all a blur, but in the past 14 days, and I've literally just put these slides in. The patient came into me, they're a regular patient, and they chipped a front tooth. And I've got 30 minutes before my lunchtime to fix this up. I haven't got time for 3-hour layering of a front tooth. So I need a composite which is going to provide an aesthetic result, which is easy to use, which has the physical properties that are able to withstand the forces that we need anteriorly as well. So this is the existing restoration, and you can see there's some stain. The patient says they've fractured the tooth and they need it fixed ASAP for a meeting. In all reality, if you look at this restoration, the stain on the surface probably indicates that they fractured a little while ago, but they had a meeting coming up and they needed it done today, as they all do. So what do? I actually get some composite, any composite, I roll it up and I put it on with my thumb and I blend it across the surface. And what I can do is I can make a mock-up. Now, an even better way to do it is actually to use that composite as well to do your shade selection. And in this case, I've got a Simply Shade Light, or a simplified light shade here. And I've put it on the surface with my thumb. I've actually used my thumb on my finger on the back of the tooth, and I've used my thumb on the front, and then I've used a flat plastic around the edges. The shape isn't perfect. I probably got a disc after this and just evened out the incisal edge, but I've checked shape and I've also checked shade in one single go. And then I've got my putty key, and I've taken a small putty key just behind the front 2 teeth. Okay, so the benefit of that being that I've got the shape and I've already got the color at the start of the appointment. I then put a retraction cord in. I didn't use a rubber dam in this case. I can use an OptiView, and I can use a retraction cord to help with retraction and to help with gingival clavicular fluid. I'm not too concerned with gingival clavicular fluid coming out of the sulcus because my restoration is right on the incisal edge. But for peace of mind, I still put my cord in, a 000 retraction cord. Okay, I remove the restoration and I apply a small bevel. So how do we hide the restorative margin between a tooth structure and the composite? We need to put a bevel of some sort. Now you'll see some composite artists basically creating these beautiful composites without any bevel. And, maybe they've got hands which are amazing hands and amazing techniques, but for the rest of us mere mortals, we need to have some sort of a blend. And for me, I do a wavy bevel. So that means that I get my red, I get either a disc or I get my red point diamond, and I basically angle and I create a little bevel and I make it wavy. I don't create a straight bevel because a straight bevel will pick up the light. So a wavy bevel like this will allow the light to disperse and you won't see the transition between composite and tooth. This is a Simply Shade Light. I've put a little palatal increment and then I've put a little buccal increment. I've used my instrument to then put it in place. And I've then, after this, basically immediately need to do some polishing. You can see the surface is a little rough, but you can see within 30 minutes, I've created an acceptable restoration. The shade is going to get better and better and better with time as well. Now, you might ask me, what about those cases, Aodhan, that you've got this beautiful incisal translucency? How can you create that with one shade? Well, what I've been doing, and I haven't heard anyone else really talk about this, but something that you can do, and I recommend you try, is cut back that incisal 1 or 2 millimeters, okay, and actually apply some harmonized clear or harmonized incisal to that area. And it's the same technology. It's the same sort of It's the same basic a type of resin material and resin technology. So there's no reason why you can't add the two materials, but that allows you to have some incisal translucency with just one extra step. Now, you might ask, when would you do that step? Would you add the whole, if we go back here, would I add the whole increment of Simply Shade Light here and then cure it and then cut it back? I would say no. I would add the increment and then cut it back with my instrument and then add the translucent and mold them together. Okay. By adding two layers that are uncured together, you're actually able to manipulate them and blend them much better. Okay, but I want you guys to give this a go. Let me know what you think. I've started doing this with restorations. Like before, when I've got that girl with the two front teeth, I could have probably avoided all of that 3-hour appointment by using a Simply Shade Light and then using an incisal clear, basically to give that translucency. This is a case where a patient's come in. He is a famous restaurant owner. He's a lovely guy. And one of his habits used to be chewing seeds. So he'd chew seeds. He's Turkish and he'd chew the seeds as habit, as part of their culture on the front two teeth. And you can see the damage he's basically done to these teeth. And he said, Aodhan, I've stopped chewing the seeds. I've given up that habit. I really want to fix these teeth. I'm not quite ready to go to an indirect restoration yet. You know, I don't want veneers, is his words. But can you give me an alternative that is able to be done in one appointment because I don't have a lot of time? And I said, yes, listen, let's use some composite. Why am I using composite? Because I've got so much enamel. I have no qualms with bonding composite or adhering composite to a case like this. Why? Because so much enamel is going to give you such a huge amount of surface that you can adhere to, and your physical properties, you're not going to have any issues with. Okay, he can't chew the seeds again. And if he's a grinder or a bruxer, you need to make them a night guard. Okay, but you'll see this case here. These are the fractured incisal edges. And I made an error here because I put the rubber dam straight on without doing my mock-up. Okay, so this was probably about 6 months or 12 months ago. We've had Simplify for a little while here in Australia. So we've been your test dummies basically, but I've applied the rubber dam before I've actually done a mock-up, and you'll see why that didn't work in my favor later. But I've essentially isolated with that split dam technique again. You'll see that technique I use all the time. Again, one corner of the dam over the clamp, you stretch it across to the other side and then flip it underneath the lip. Apply your PVS then to the pullet, and you have a surface where you can work that doesn't allow the water to go down the back of the throat. I've done my mock-up and I've also done my shade selection in one go. And I saw this, I looked at this case and I knew immediately it wouldn't be a light case, it wouldn't be a dark case, it would be a medium case. And the more and more you do, the easier it is to select shades, especially when you've got such a small number. He's not a bleach, he's not an opaque, he's not a dark. And it was either between a medium and a light. And you can see that the teeth have that yellow hue. So it's definitely not going to be a light. So his is a medium. I've mocked it up, and I mocked it up basically based on what an eyeball technique of what I thought would look nice. And I've done a direct mock-up, and this is the putty key I've taken. So you can see here, I roll up my putty key and I put it behind and it records the shape. And then I can just flick off that direct mock-up. And that saves me doing a wax up. How do I know how much composite to add to the putty? Well, I get a sharp instrument and I run my sharp instrument along the edge, and that allows me to see exactly how much composite I'm going to be adding to the putty key. And you'll see that some people will apply the putty to the tooth first and then get composite and put it on top. But I will have less control over how much I'm adding to that and my thickness of my layers by doing that technique. So for me, I actually add it directly to the putty key and then I put it onto the tooth and cure it. So you can see here exactly how much I need to add above the scribed line.
We're scribing a line along the putty key so that I know where to add the composite resin. So what it looks like is we place the putty key into the mouth like this. We take a sharp instrument like a probe and we run the probe along the edge here, a bit like this. So then when we take the putty key out and we have a close look, we can see the scribed line running from here to here. And therefore, this is where we're going to be adding the composite resin to the stent so that we don't have excess.
So you can see that I've marked it. I know how much composite I'm going to add. I have then prepared the surface. And as I said, the two ways I prepare the surface is either with pumice. Okay, so pumice, if you just have pumice, or I need to use air particle abrasion. So why do I need to clean the surface? Well, one, I want to get rid of all the plaque, the bacteria. I want to have a nice clean surface. The other thing that I need to do is I need to make sure that I'm getting rid of the surface aprismatic enamel. So that aprismatic enamel, we'll all know that there's different types of enamel: prismatic, which has a little pores, and then aprismatic, which is all over the shop. You can't adhere to aprismatic enamel to the same level that you add to prismatic enamel. So what I need to do is, if I'm using pumice, I need to get a diamond burr and lightly roughen it. I need to do my bevel as well. And with the air particle abrasion, it's able to remove that surface layer as well of aprismatic enamel. So there's a tip for you guys. If you're having failures of anterior composites, it may be just down to a simple thing like that, because you're essentially limiting the physical properties of your composite if you're not doing that. So surface is prepped. I've used OptiBond Universal in this case. How do I protect the adjacent teeth? When I'm doing my etching, when I'm doing my my bond, well, I just should get some Toffelmeyers or some clear strips and I just roll them around like this. That means that I'm not going to be adhering the teeth together and bonding them together, which isn't the end of the world if you do it, but I'm not going to bond them together, and it's going to make my next steps a bit easier. I apply my composite to this stent that I've taken, the mock-up stent, and you can see I do a clear line down the middle so that the composite isn't connected. So that's what I call my palatal shell. I then apply the palatal shell and I cure it. Now at this stage, say you forgot to get your instrument and you forgot to separate the two parts of the shells. All you need to do, you don't need to panic or anything like that, is get a flat plastic, put it in between the contact point, okay, where that little black triangle is there, and turn it to the side, and you'll hear a click and the restorations will pop open. Okay, I just tell the patient, listen, you'll hear a little click here. I put it in, turn it, and it clicks it open. And I always do that whenever I'm doing any anterior composites, because I want to make sure that my palatal shell or my composite itself isn't bonded together. Okay, so instead of trying to get a proximal saw or a strip in there to break it apart, don't do that. That will ruin your restoration. Just get an instrument and put it in between and click it and turn it. Okay, so that's the next step. This is Simply Shade Light, Simply Shade, I think moderate for this, or medium, I should say. And I've made a putty key. Now, basically, this is a tip for how to remove your putty key, because sometimes your putty key might actually get bonded to the restoration and the teeth, and you might break your palatal shells off.
So a little tip for taking the putty key off without breaking the palatal shells off is to put one finger on top of the putty itself and to have an instrument and run the instrument underneath like this, applying pressure, but then rolling your finger back slowly, one by one, and you'll see the key come away from the composite. I'm not pulling it all off in one go. And there we go.
So that's allowing me basically, like, you could do these techniques with freehand technique. You could use a Toffelmeyer. You could just use a mylar strip. But why I use the putty key is because the putty key guides my whole shape. And you'll find that there's a much less finishing and much less adjusting and polishing later if you do a putty key technique. And we can always talk about that during the Q&A and after. I use a mylar strip in between and I form my buckle layer. So forming the buckle, that's my buckle. Now, I was looking at this and I was thinking, maybe my teeth look a little bit, the 2-1 and 1-1 look a little bit too long here. And I was unsure. I did some contouring and polishing, and you'll see that they were too long, especially when I sat the patient up and I looked at them in the mirror. They looked like they're a bit of a Bugs Bunny look. The front two teeth were too low. Okay, so that was my mistake in not doing a mock-up with the patient, seeing it and seeing their smile. And I accidentally did the mock-up with the dam on already. Now, these are markings of the line angles, and this is really crucial. So what is a line angle and why am I drawing it in pencil here? Well, a line angle is basically where your facial surface and your proximal surface meet, and it creates an angle or a line. And on these ones here that I've marked, these are between your proximal and your facial. So we call that a facial proximal line angle. Now, these are very, very, very important. They're probably one of the most important steps in finishing and contouring of your composite. And the reason why is that it actually gives your eyes the reflective surface from the composite. And if you don't have them symmetrical or you don't control where they are, they will either make your front two teeth look asymmetric, or they can make them look too wide or too narrow. So I can actually adjust these and push them out and make the tooth look wide, or I can push them in and make the tooth look narrow, even in the same shaped tooth. Okay, so the same shaped tooth can appear wider or narrower depending where these are. So if you look on this one here, you'll see that my 1-1, the tooth on the right, doesn't look too bad in terms of that line angle. It looks quite nice. You'll see as a reference, look at the 1-2. Can you see that 1-2 has that beautiful light reflective surface there? That light reflective surface is what we need to create. But you can see on the 2-1, the central incisor on the left there, that the line angle is not correct. It goes way too far in. I actually need to push it. And what I need to do is get a burr or a disc, and I need to move it side to side. So I need to mark the line angles, and I need to move this one in. And I actually use my burr in a motion side to side, and I actually push the line angle. And this is what I create. So I've created these nice defined line angles. And when the pencil isn't there, the light will reflect off them, and that will control the apparent shape of my tooth. And you'll see from here to here is a big change in length. The reason why is I sat the patient up, they looked at their front teeth and they said, Aodhan, the front teeth are way too long. And I said, I agree with you. I marked them with pencil, and then I actually adjusted them. They look too short here, but you'll see shortly when we look at the smile, it looks nice. So I've got my line angles marked in the pencil, and then I mark my secondary anatomy. What is the secondary anatomy? The secondary anatomy are these little triangles. So the triangles on the incisal edges are the secondary anatomy. And those are areas where they're actually depressions. We get a burr and we file out those areas dependent on the adjacent teeth, depends on how far you file in, but that is what a natural tooth has. If you look at your tooth in the mirror and you run your finger across, you have little ridges, and those ridges actually are the natural anatomy. And what happens is, if you look at the 2-1, the central incisor on the left there, we have the two triangles, and either side are basically tooth structure. So those are called the lobes of the tooth. So you've got your mesial lobe, and then your mesial depression, your middle lobe, and then your distal depression, and your distal lobe, okay? So it goes mesial lobe, mesial depression, middle lobe, distal depression, distal lobe. And that's the surface anatomy that you need to create. And you can create that with your burr. You can see here, I've got some beautiful secondary anatomy. It's symmetric, so I've controlled that shape of the tooth. And you can actually see I've created these secondary anatomy areas which allow the light to go in and reflect, and essentially it creates that natural appearance of an incisor. And then I use the high luster polishers. This is how I polish my composites. These are from Kerr. Basically, there's a blue rubber and a gray rubber. I use those after I use my Opti discs, and I use my Opti discs from red to a dark orange to medium orange and then to yellow. And then I use my high luster polishers, which have diamond impregnated in them, and I buff the whole restoration up. Now, do I do these steps for every single patient? No, it depends on what the adjacent teeth look like. If your adjacent teeth are super shiny, then I would go through all of those. If your adjacent teeth are quite matte, then you probably don't want to go through all of these steps, because you're going to create some restorations which are very shiny while the other teeth have got a rough and matte surface. And this is immediately post-op. So you can see the light reflects beautifully off these restorations. And in his smile, you've got that beautiful smile arc, okay? They're not too long, they're not too short. So that was a Simply Shade medium case, or a Simplify medium case, both the same material. This patient here, came in and she said to me, listen, I dislike my fangs. They're really sharp, her canine she's talking about. And I don't like that I've got these little teeth next to the big teeth in the middle and the fangs, and they look out of place and I've got gaps. She's very much class 2. And I got her to see my local orthodontist, who I work with very closely, and they offered her either an extraction-based therapy of class 2, or they offered her orthognathic surgery. And she didn't want these treatments, okay? So you'll find a lot of your patients won't want to have that sort of thing done. For me, this is a case where I can do some Invisalign to straighten the teeth and put them in the best place before I do my composites. And she's fully aware that this is not the ideal. The ideal is either surgery or fixed orthodontics with the orthodontist. But she had a 6 months time limit. And in that 6 months, you'll see what we were able to achieve. You'll see that 2-2, the upper incisor, the lateral. And I'm sorry, I can't remember if you guys use the same tooth number system as us. But essentially that 2-2 there, which would be like a 9 or a 10, I think, which it can also be called, you'll see the gap is quite a large gap, and you'll see it looks really narrow because it's rotated. But that tooth is actually the same size as the corresponding tooth on the other side. She's got these really pointy teeth as well, and they're quite yellow, which she didn't like. So I did some Invisalign, and you'll see here she's very class 2. And you'll see that she actually had a little space on either side here. And what I was going to do is basically derotate the teeth, align them. I use attachments, which are optimized to help my tooth movements. And I'm able to put the teeth into a place where my restorative procedures will look the best they possibly can. I could do some composites without doing this alignment first, but my result wouldn't be as nice as if I did these 7 weeks of aligners beforehand, essentially less than 2 months of Invisalign for this patient, or aligners. And you can see we're intruding the uppers a little, intruding the lowers, and we're leveling that incisal edge, and we whiten the teeth. What kind of whitening do I use? Well, this is always something that people will ask. You know, I do another tip for shade selection is just get the patient to whiten their teeth as much as possible, and it limits the shade selection down again to 1 or 2 shades, and it's probably going to limit down to 1. So the whiter the patient's teeth, and I'm very lucky in that a lot of my patients want to have white teeth and want to whiten their teeth, but the whiter the teeth, the easier it is to select shades. You're not opening that tackle box that we talked about before, trying to select 50 different, looking through 50 different shades. For a bleach shade composite, a bleach shade enamel, basically I'm going to use one composite, and it's your simplified bleach. That's it. It eliminates all the airy-fairiness and you know, the panic in the back of my mind about selecting the wrong shade. So I get all my patients to whiten their teeth before we go into doing their direct composites, and they love whitening. They want whiter teeth. So it's good for everyone, good for me, good for them. I use tray whitening for all of my whitening procedures. I make custom trays based off a digital scan or based off an impression. And the custom trays I get the patients to use for 4 weeks at home. And I give them either 10% carbamide peroxide during the day, during the night while they sleep, or I give them 35% carbamide peroxide during the day for 30 minutes. Okay, so nighttime, 10% carbamide peroxide, or daytime, 35% carbamide peroxide for 30 minutes. So those are your 2 different options. And I tell them, do it every day for a month. Why do I say that? Because the patient's definitely not going to do what we ask them to. They'll probably do it every 2nd day. And how many days do I really need them to whiten for? I need them to whiten for at least 14 days. So 14 days to 21 days, 2 to 3 weeks is what I need them to whiten for. And they'll pull all of the stains out of the enamel. And if your patient asks you, is it going to damage my teeth? You say no, because there's no evidence that it will. What it'll actually do is break down stains that are already in your teeth. And those stains got in there through the little pores in the enamel, and they're going to go out via the little pores in the enamel too. So it doesn't need to damage the teeth or damage the enamel. I use the trays, I get them in for a review and then I do my composites. So I should say, how long do I wait between whitening and my composite resins? I need to wait 10 to 14 days with no whitening at all. Why? Because the bleaching free radicals will stay in the teeth for 10 to 14 days, and that will reduce the ability for your composite to adhere to the tooth. So if you do a whitening session, an in-chair whitening session, for example, or an at-home whitening session, and you bond to the teeth immediately, you're really compromising your final longevity of your restoration. And the reason why is because those free radicals are bouncing around in the tooth, and they prevent the actual adhesive from doing what it needs to do, going into the tubules, etc., and your composite will fail faster. Okay. Another question someone might ask is, why don't you do in-chair whitening? Well, the thing with in-chair whitening is that in-chair whitening will often, one session will give you an immediate result, but that's mainly also from not only the bleaching factors, but from dehydration. So I find that a week or two later, it goes down again and it gets darker in color. So I always prefer to do take-home trays and do it for a month. This is the immediate result. You can see a little bit more polishing is needed, but you see I've used one shade here. This is a Simplify or a Simply Shade composite resin, one shade. You can see it looks beautiful in terms of the color. It looks amazing. In terms of the shape, I've matched the lateral incisors and the centrals and the canines by doing that pre-ortho. So by doing the ortho with Invisalign beforehand, I've been able to match the shapes much better because that 2-2, the upper left lateral incisor will have looked much narrower than the upper right lateral incisor if I hadn't done the alignment. Okay, you can also see the chameleon effect that this Simplify composite resin has, the Simply Shade. It's really, really beautiful. It blends in. You can barely see the transition between tooth and composite. And this is the patient before and after. You can see the difference in the smile. You can see the awkwardness in the smile where the teeth are narrow. I've actually, with my Invisalign, also brought out the premolar teeth to broaden her smile. But you can see that balanced, nice smile matches her lower lip line. Okay, you can see it here as well. That lower lip line looks beautiful now, matching the incisal edges of those incisors as well. And the color's perfect. The color's absolutely beautiful. And this is from memory a Simply Shade Light or a Simply Shade Bleach. Basically, I basically only use two colors, and it's one of those two. Now, the last case I want to talk to you guys about before some Q&A, the very last case is what we call edge bonding. And in Australia, this is quite popular. And edge bonding is where you don't cover the entire facial surface with composite, and it's where you just add to the incisal edges. And you need to be very careful in your patient selection. They cannot be grinders or clenchers, or if they are, they need to have a night guard to wear. But what that does is basically, if the patient is happy with the shade or the color of their current teeth, you can actually lengthen the incisal edges or close up the incisal embrasures by just adding composite in here. Okay, so this is a patient. She came to me. She's 25 years old. She didn't want to go to do indirect restorations, which I agree with. She disliked that her front teeth were quite flat and short and that her premolars had big gaps between them. And these are her teeth here. You can see that the enamel is quite patchy. And you can see that the incisal embrasures, aka the opening between the edges of the teeth, needs to be symmetrical, and it's not here. It's also the incisal edges are unlevel as well. So this is what she's looking at. Most people would be happy with her teeth or a smile, but she wasn't. She does modeling and things like that, and she needed to have a perfect smile. So what we did is we did our bleaching. She got some in-chair done. Why? Because she was really set on also getting in-chair whitening. Okay, if the condition for me is if you do in-chair, you must do take-home whitening beforehand as well. Shade selection, shape selection. Shade selection, Simply Shade Lights. It was a no-brainer, very easy. Shape, I sat down and I drew this shape with the patient to see what they thought of the shape. The other thing you can do is you can do a mock-up with material on their teeth. Don't bond it, and you can even take a putty key from it. In this case, I actually did freehand, and I was able to use the single shade, and I was able to basically even all the incisal edges and those incisal embrasures out. And you can see that the blend is perfect. The blend looks really nice. She needs a little bit more polishing for these restorations, but we were able to achieve an aesthetically acceptable result with a minimal intervention. There's no enamel preparation whatsoever. We just cleaned over the surface and aerobraded the surface. And these restorations have been essentially in her mouth since Simplify or Simply Shade, as we call it, came out. She was my first patient some 2 years ago, whenever it came out in Australia now. I have her, she's got big jaw muscles. I've got her wearing a night guard. I've got her also protecting the restorations by not chewing on seeds and nuts and things like that, and watching out for olive pips and all of those sorts of things. For her, composite is probably a good transition before she goes down the line to maybe do porcelain in the future when she's in her 30s. But at this stage, I always try and push that restorative cycle and the entry point to indirect restorations down the line. Okay, so you can see this is her smile here. You can see the enhanced smile, closing up those gaps. Using a night guard is very important. And this is her smile here. So both of these patients have actually had work done by me with some bonding and veneering and things like that. That's us. That's the initial chat. So Sis, if you want to hop back on, I'll stop the screen share here.
Thank you so much, Dr. Aodhan. Brilliant session. I think great tips and tricks shared with everyone. Before we go forward, can I please request all of our doctors to just take a couple of minutes to fill out this very quick survey form that's up on the screen now. And that will really help us to understand your requirements and also better design our future courses. And soon after this, we will move on to our Q&A with Dr. Aodhan.
I'm just going to grab a coffee.
Yes, no problem.
Cool.
Thanks. Okay, thank you so much. We will move on to the Q&A session now. We have a couple of questions here in the chat box. Dr. Aodhan, I think if you could just see those. So the very first question is, which cases would you use a Simply Shade universal opaque for?
Yeah, so universal opaque can be used for example, a patient who wants, I've got a very aesthetically driven group of patients. It may be the patient who really likes an opaque white looking composite, and that's not for everyone. I personally don't like the appearance of really opaque restorations, but some of my patients love it. Some of my patients really love opaque white. The other cases that you can use it in is actually to mask a discolored tooth. And it actually can be really useful to mask a stump shade that is dark, for example. You might be using it underneath, you can actually use it for underneath a crown preparation, for example, where you've got a dark stump shade and you cut it back and you layer some opaque composite on top to mask the discoloration coming through. So there's lots of different ways you can use an opaque composite. You might even use it, for example, in combination with a lighter composite on top for some veneering, for example. So you might have a case where you've got a dark stump shade. You may need to cut the stump shade back. For example, you may need to do some preparation. And then what you can do is you can put some opaque composite and then you can layer over the top some light or bleached composite as well.
Okay, thanks. So the next question is how to treat discolored teeth with simplified composites. Any tips?
The main tip would be to bleach them first. So if I've got patients with dark stump shades or discolored teeth, I never jump straight into doing composites for them. I get them to bleach and I tell them that sometimes it can take up to 2 months. So if they've got really dark or stubborn colored teeth, I do external custom tray whitening with that 10% night or 35% day. And then I would go to the stage where I do the composites. If they have an endodontically treated tooth, you might need to do internal whitening, for example, with some whitening gel as well to balance up the color. I always get the stump shade, the correct shade, before I go to do anterior composites though.
Okay, the next question, it's a very common question that we often hear about how to treat white lines in restorations.
Yeah, good question. So white lines can come, yeah, they're like the mysterious thing, like why are they happening, why are they occurring? They can occur for different reasons. One might be overheating. Okay, so if you overheat your composite during finishing and contouring, and polishing, I should say, you can sometimes create a white line. That's one reason why. So I use, when I finish, I make sure that I'm using either water or if I'm not using water, that my nurse is blowing air onto the tooth so we don't overheat the teeth. The second reason why you might get it is, for example, if you've got an undulation or basically like a little divot in the tooth between layers of composite or between increments of composite, you might get a little line which forms as well. So in those cases, you need to actually polish it back, or you need to make sure you blend your composites. So if you're blending your composite, for example, you need to make sure that, as I was saying during the talk there, I always blend them without curing them. So I'll actually add an increment and then add another increment and then blend the surface. And then when you polish back with a disc, you're not going to see that white line that forms, that little line in there as well. Those are two of the most common reasons why you'd get a white line in your composites, for example.
I hope
and actually, I should say another one is that if you're applying layers, like say you've got a class 1 restoration and you fill the whole class 1 restoration, like class 1 being just like a box on the occlusal. Say you do one single increment of a composite that is not a bulk fill composite or something like that, you will probably see a white line around the margins. Why? Because you're getting polymerization shrinkage. So you need to layer appropriately to prevent shrinkage, and you need to actually try and maximize shrinkage of that layer towards the tooth structure. So if it's a class 1 or a class 2, whatever it might be, and you're getting a white line basically around the edges of the box, you need to put a layer over the dentine. You need to build one wall up and then build the other wall up on top.
Right.
I hope that helps.
Wait, another question. How do you blend the margin of the edge bonding if no tooth preparation? Yeah,
it's pretty tricky. You'll always have a margin present. Now, the trick is shade selection here. And in terms of hiding the margin, you need to thin that composite out incredibly thin and get a high polish so that it's harder to pick up. You will always, though, have some visible line, especially if someone is looking really close, or especially if the composite is getting worn. So the more wear the composite has with time, the more you'll see that that line, the more chance of staining, etc. So getting the composite highly polished is one tip. And the second tip would be that at your maintenance appointments where you're doing like when your hygienist is polishing and doing hygiene to get out some rubbers and polish again.
The next question is, for the last case, doctor, did you do direct composite veneers? Can you tell more in details about the procedure done for the patient, because it looks like the patient had fluorosis?
Do they have direct? Sorry, let me see if I can read that just because I missed the first bit. For the last case, did you do direct composite veneers? I did direct composite, but what we call edge bonding, so no veneers. Can you tell me more details about the procedure done? Yeah, so essentially for that last case, what we did is we did teeth whitening first. And the second thing that we then did after the teeth whitening is we air particle abraded the surface. I didn't do any prep at all. So I didn't use a burr. I didn't prep into the teeth. But the air particle abrasion basically helps to remove some of the aprismatic enamel. And then I used my adhesive, and I added composite. Now the composite only goes up the tooth a few millimeters. It didn't cover the full facial surface of the tooth. And that's something that you guys might need to look into, but we call it edge bonding. And it's something which if a patient has a nice color of teeth, then you don't necessarily need to veneer the whole surface of the tooth. But obviously there's pros and cons. By not veneering over the whole surface of the tooth, they need to maintain the color by doing some whitening. So I make them some trays after, so that they can whiten the tooth structure adjacent to the composite. You need to make sure, as someone else has pointed out really well, you need to make sure that that dividing line between composite and tooth doesn't become apparent with time, which it always will. So you need to make sure it's regularly buffed and polished. And that you take stains out as well. So your whitening can take stains out of the tooth structure. You're maintaining that high polish count as well.
Going to the next question.
Yep.
Could you simply shade for direct veneers?
Could we use Simply Shade for direct veneers? Yeah, that second last, like the second last case was Simply Shade for direct veneers there. Yeah. 100%. Yeah, I only use Simply Shade for my direct veneers. Now I actually don't use any other material for direct veneers. I use Simply Shade Light or Simply Shade Bleach. Those are the only two that I use for my direct veneers. As I said, superior physical properties, excellent handling, color is beautiful. It has a nice, it just looks beautiful.
The next question is, if you cut back the composites and layer after, do you etch and bond the composite before layering over it?
Yeah, the trick is not to cut it back. So the trick is just to layer it on top of the composite that's uncured. But this is a good question. A lot of people ask this. So you want to minimize the amount of times that you're going to be actually like if you've got a composite surface and you're then cutting it back and applying adhesive to it, you're creating a weak layer in between. So the trick for me, and this is what a lot of other clinicians do as well, is that we cut it back with a dry burr and with air. So there's no water. Okay, so we cut it back and then we apply unfilled resin, which is commonly called modeling resin. And we clean the surface with modeling resin, and then we actually apply the next increment. And that means that I don't have to etch and apply my adhesives and create a weak layer. So every time you put bond in between your layers, you're creating a weak layer of basically in the structure. I never use bond that is a filled resin. Like I never just open a bond bottle up, and I never put that on a surface. I never use that to finish my restorations or anything like that. That's a big no-no. You'll ruin your surface, but you'll also, like, it'll be nicer to handle, but you'll make you'll basically create a weak point for the tooth, and that will impact the surface integrity. You should use modeling resin for that, which is an unfilled resin.
Okay.
I hope that.
Another question just related to this is, how do you repair old stained composites or composites that have fractured and chipped?
Yeah, this is important. You need to, during the communication phase with the patient, I always say to them, we can repair chips and breakages, but after X amount of days or a short number of weeks, the ability for the new composite to bond to the old composite is essentially nothing. Like there's zero bond between there. You're essentially doing it with mechanical retention. So if you're trying to bond to old composite, you're actually not going to be able, there's no active polymers, unreacted polymers still within the old resin. So you're not actually going to get a join between there. So repairing, you usually need to take it back to tooth structure. And then I just use the same shade that we used previously so that I've got, it takes longer, but I'm essentially then creating a new veneer or a new edge bonded composite area.
Right. The next question is from Faiza. May I know usually how many cases can be treated with one shade of Simply Shade?
So I don't use syringes. I use capsules. I might be a bit different to a lot of people, but for, 10 years now, I never used a syringe. The reason why is because I like to have capsules where it's the unidose capsules so that I'm not keeping my composite for months and months and years and years and years. I go through my capsules and they're really fresh. I couldn't answer how long the syringes will last for. Maybe Assis can let us know a bit more about that. But my capsules, for example, say I'm doing 10 teeth with composite, I'll probably use 5 or 10 capsules of composite for that.
Each capsule is about 0.25 grams.
Perfect.
Okay. All right. How would you simulate white or fluorescent spots when you're using composites?
Yeah, good question. I use Kerr Color Plus for all of my fluorosis spots, and less is more. If you go and Google this now, Kerr Color Plus, and color is with a K, look that up. You'll see that there's probably like 15 or 20 little bottles in there. That will probably last you your entire career. No joke. You need to use the most minimal amount of that possible. I use it on a micro brush, and I usually put it underneath my final layer, or you can put it on your surface layer. Okay, so I want to talk about both of those. So the white tint that you use, basically you express white, and I get the nurse to express the tiniest bit onto my glove. I then get a micro brush or a probe, and I put it onto the tooth surface. I then use my micro brush, and I then make it, basically I take it off so that I can barely see it. It sounds silly, but it's like, if you can see the white tint on your composite, after it's cured and looking at the patient once it's rehydrated, it will be too much. So you need to use the least possible. And if you put it on the final surface, it will flake off with time. But if you put it underneath a final layer, then it'll shine through, and you'll have that last essentially for the lifetime of the restoration. So Kerr Color Plus.
Right. And there's this question regarding the last case that you shared. I noticed that after in-office bleaching, the patient's teeth have distinct colors for the cervical and the incisal part. Why is it so?
I can't remember exactly when the photo. So that photo itself where the teeth look quite dehydrated, I believe that photo was taken at a different point in time. But so I don't want you to focus too much on that single photo. But what I should say is that with bleaching of any type, you will always have a cervical area which is darker than your incisal or middle third of the tooth. And the reason why is for a few reasons. If you're doing tray whitening at home, your saliva ingress will come in and will decrease the concentration of whitening gel at the cervical level there, okay? If you're doing in-office bleaching, when you put your light cured gingival barrier, some of that barrier will inevitably be covering the tooth structure on the gingival. So the gingival 1 millimeter. So basically for all whitening, you have to prepare the patient to know that the gingival, very, very gingival millimeter will always be darker. It is much easier to whiten the incisal edge than it is the middle or the cervical third as well, because essentially your dentine is thicker at the gingival and middle than it is at the incisal. And to whiten those thick areas is much more difficult than it is to whiten the edges of the teeth. It's all down to the thickness of enamel and thickness of dentine at those portions.
Right. And then related to this question, what are the indications for home bleaching and in-office bleaching respectively?
So for me, the indication is always to do home bleaching. And I only do in-office bleaching if the patient really wants the in-office bleaching. But the caveat to that is that they must do home bleaching beforehand. Now, that's just me. A lot of people will let patients tell them what to do. I never do that. I tell the patient what they need to do. You know, if they want to do whitening and they want to do it with me, they need to do it the way that I do it. And the reason why is because if you guys change to this technique of doing the at-home whitening and then doing a bleach in the chair, you'll never go back because the results are much, much better. Your before and after are miles away from just doing an in-office in-chair bleaching itself.
Okay, and another question from Jolene is, what would you do if the tooth surface stains after the whitening plus the filling procedure is completed and there's a difference in the color between the composite and the tooth?
So, good question. If there is a difference in color, darker, then that's okay. You can probably make some trays up and get them to whiten it up a little bit more. If the color is lighter, then you need to cut them off and do it again. Simple as that. And that's why we need to have a simple technique in terms of shade selection. And that's why something like Simpler Shade simplifies the whole process, because you have less choice and there's less room for error essentially in your shade selection.
Right, and this is the final question that we have in the chat box. For the cutback technique you mentioned, what composite do you use on the incisal edge after the cutback? Enamel shade composite or translucent shade composite?
Yeah, good question. So say I'm doing Simply Shade for the whole restoration and I cut it back. If your incisal edge is really translucent, then that's when I would use a translucent shade. But if you're, and when I mean cutting back, I mean that if this is the restoration here and we're looking at the tooth from the side, I'm cutting it back at 45 degrees. I'm still leaving some of the composite here. I'm not chopping the whole edge off. You need to, if you look at the adjacent teeth pre-dehydration, and if it's very translucent, then you can use a translucent shade. If it is moderately translucent, you can probably use an enamel shade over that as an alternative over that, like a harmonized enamel.
Another question is, what software do you use for smile design?
Yeah, so you could use multiple software for smile design. I traditionally just drew with my pen and paper, but I started doing a lot of PowerPoint smile design. You can Google Ed McLaren PowerPoint smile design or Ed McLaren Photoshop smile design, and you'll have tons of free papers. Tons and tons of free papers. Otherwise, you could do DSD, Christian Coachman's. Otherwise, you could do Trios smile design. There's a lot of different smile designs available there. So yeah, I meant to also say, if you guys have got any questions, feel free to add me on Instagram at dr.aodhan, so Dr. Aodhan on Instagram, and ask me any questions. You know, it's nice to share the love. You can post about this webinar, post about Kerr, post about Simply Shade and what you've learned today. I'd love to see that. If you've got any more questions, please shoot them through before the end though, and we'll answer them. But it was lovely having everyone today.
Thanks, Dr. Aodhan. And there's Dr. Jolin says, thank you so much for sharing the knowledge and experiences. So that's great.
Thank you. My pleasure.
And I don't see any more open questions, but we have a couple of minutes. So any other questions, please just type them in the chat box.
Anything you want to ask? Any burning questions?
Well, many of these questions regarding, you know, the white line is a very common question that we come across.
Yeah.
And then Another question that comes to my mind is indications for universal opaque Simply Shade versus the bleach Simply Shade.
Yeah.
Where would you use universal opaque versus the bleach white?
Yeah, my bleach would be for most of my patients that want to have a nice bleach composite veneer look. But if the patient really likes that fake opaque look, that I don't know if you know the look, the really fake look, where they want to have no light transmission at all, and they want to have a very kind of they want to have a really blocky fake look, then that's what I would use for my composite veneers. I don't like that look. I like for composite veneers that much, like a really opaque look. I like a bleached natural look to them, but some patients come in and that's what they prefer.
Yeah. Another indication that I would imagine would be maybe to block out any discolorations.
Of course. Yeah. So as said, you can use the universal opaque to block out a dark stump shade. So say you've got teeth which are darker and they won't whiten up more, you might need to do some preparation to actually give some space, but you could layer universal opaque first, and then you could put a bleach Simply Shade on top of it actually. So that might be an indication, but also just in general day-to-day dentistry, when you've got a dark stump shade, say you've got a restoration that's really dark, and you're doing a crown prep, you can actually cover that with the universal opaque, and it really blocks that out. So it stops for example, you might do an Emax or a Lissy crown. It'll stop the shine through from the dark stump shade coming through, and you'll have more of an opaque and a nicer balanced color underneath.
Right.
So not just for cosmetic dentistry, you can use it for all dentistry, really.
Yeah. So thanks for that. No more open questions in the chat box so far. So I'd like to thank all of the doctors that joined us today, and giving up your Sunday morning to join us online. We also have promotions on Simply Shade, OptiBond, and Maxim in each of the markets. So do reach out to your local Kerr representatives for details. Also, a very special thanks to Dr. Aodhan for sharing optimal protocols and clinical tips and tricks that will help the audience simplify their Resin artistry. It was a very insightful session for all of us. So thank you again. Hopefully we get to see you in person very soon.
Thank you. I'd love that. I'd love to meet you all in person. I'm sure it'll come around soon. And thank you all for joining.
So thank you, everyone. We will end the session now. Have a great rest of your day. Thanks, Dr. Aodhan.
Thanks, guys. Catch you later. Bye-bye.
Bye-bye.